Okay. I want to thank Dr. Valcavi for invitation. It's a pleasure and an honor to be here with Professor Beck, who is the world leader in radiofrequency ablation. Then I introduce the first speaker, who is Dr. Valcavi, Thyroid radiofrequency ablation of benign nodules. Please, Roberto.
Good morning. My presentation will be on radiofrequency ablation of thyroid solid benign nodules. I will review with you some important items taken from the 2017 Thyroid radiofrequency ablation Korean guidelines made by Professor Beck and co-workers. As regards indications, what are the indications for solid benign thyroid nodules? Patients complaining of symptomatic or cosmetic problems who are not suitable for surgery or refuse surgery. Benignity should be confirmed on at least 2 ultrasound-guided fine needle aspiration biopsies or core needle biopsy. Single benign diagnosis on FNAB or CNB is sufficient when the nodule has ultrasound features highly specific for benignity, for instance, spongiform nodules. Single benign diagnosis on FNAB or CNB is sufficient for autonomously functioning thyroid nodules, AFNT, and I will show one. RFA can be indicated for either toxic or pre-toxic AFNT. Laboratory testing should precede RFA ablation. Of course, I already told that FNAB is very important to have a FNAB negative. I'm speaking about benign thyroid nodules. Imaging with ultrasound, basically, you should register features of nodule and surrounding critical structures. CT scan or magnetic resonance imaging should be obtained in selected patients. Lab tests are complete blood count, blood coagulation battery, and thyroid function tests, serum TSH, I would say reflex, and maybe serum antibodies. This is not reported in the Korean guideline. Thyroid CT scan is indicated for AFNT only. Now, I will show you some tips and tricks about the RFA ablation technique. The following slide will show you a radiofrequency ablation of a solid hot benign thyroid nodule. Again, the benign solid nodule, it was about 10 mL. The power color Doppler, the power Doppler mapping showing hypervascularity as confirmed by B-flow, and those are images sagittal and axial of the left thyroid nodule, taking with the B mode. It shows, the B mode shows compact but inhomogeneous structure, well-limited nodule, and the power Doppler shows intranodular hypervascularity. And again, the hot nodule was proven by scintigraphy. The TSH was less than 0.1 microunits per ml, and the T4 was at the upper limits. Now we are in the interventional suite at the Centro Palmer, the cyclic lamp, and the monitor. I enter and sit in the operation position. I set that is behind the patient, the head of the patient. I'm coming and I set the ultrasound skin as much as possible under direct glance. This is very important to watch straight. I'm sure that we shall discuss more on this slide in the discussion. I use an anesthesiologist, and I will show you several advantages of having anesthesia. The pros of having an anesthesiologist in the operating room is that he is ascertains that the patient has no allergy to drugs which will be administered, especially lidocaine. The anesthesiologist cannulates the vein and administrates 3 to 5 milligrams of midazolam plus small repeat propofol boli. In order to maintain normal oxygen saturation, some oxygen is administered by nasal cannula. And all the anesthesiology checks the patient's vital signs through a multiparametric monitor. The patient is sufficiently reactive and breathes spontaneously. Of course, he cannot speak. The patient stays still and doesn't swallow. The patient has anterograde amnesia, which is most welcome. Patients are happy of having to not remember anything of the procedure. And the most important part is that the operator can concentrate him or herself on the procedure only, watching all the time into the screen. Side effects and complications are greatly reduced, as I showed before. I will show before. The cons is basically the cost, and maybe that yes, the patient is reactive, but he cannot give his feedback on voice, for instance. I'm sure we shall discuss this later. In most patients, I use the monopolar system. This is maybe too high. The ground pads are carefully placed at both patients' thighs in order to create a closed-loop circuit between the tip of the needle, that will be the ablating part of the system, and the body of the patient. Ground pads should be totally stuck in order to avoid skin burns that I never observed so far. The RF generator and the peristaltic pump are placed on a trolley to the patient's feet. This is the generator, the pump, and the saline solution at 5 centigrades. Again, the generator and the pump, the peristaltic pump, and the pedal for remote control of the generator. This is our standard RFA electrode needle with a diameter of 18 gauge. Shaft length is 7 centimeter. The active tip is 10 millimeters. This is the standard which I use for most patients. Again, the slides shows, the images shows that the technician fixes the pedal in the best position to operate on and off the machine. Local anesthesia is performed a thin a small amount of 2% lidocaine, I would say 10 mLs, is given slowly, is injected slowly through a 27 gauge, 5 centimeter long needle. First, the needle is carefully inserted with a transseismic approach. The thyroid capsule is gently detached from the strap muscles, inserting with precision the thin needle, and the virtual space that becomes real. Here you see the injection of the local anesthetic, pericapsular. It spreads towards the carotid artery, not more, because you will anesthetize the vagal nerve or other nerve structures. Then it is spread all around with the probe, and the assistant pumps gently the anesthetic and retracting the needle until a small bump is done on the skin. I take care to insert the electrode needle with a transseismic approach. Needle and linear probe are aligned with minimal adjustments. The needle is inserted in the deepest part. You will see here, yes, in the deepest part of the nodule, being careful to leave space about 5 millimeters between the needle and the danger triangle, which is here. Then the needle is activated and it starts to make bubble gases. And as far as the impedance grows, the needle is retracted towards the insertion point. You should be careful not to retract too much the needle in order to avoid burning of the capsule, of the capsular part of the nodule. Then the needle is repositioned at the extreme part of the nodule in the following ablating plane, and the ablation is restarted. And again, the needle, as far as ablation progresses, the needle is retracted, the electrode needle. This is a back view. I never look. This is me. I never look away from the screen, which is in front of me, especially in the most delicate phases. During ablation, the anesthesiologist checks the patient's vital signs while I'm concentrating on the ablation. And this is a 8 per speed motion. I reinsert the needle and repeat several times the maneuver until completing the ablation area, which is becoming hypoechoic with bubble gas all around. Yes, this is to make a short, a long story. And after, the last slide showed the complete ablation by color Doppler. I adopted over the time a immediate post RFA therapy in order to minimize side effect. Tissue cooling is obtained by ice pack. Ice pack is compressed over the entry point, and while I keep pressure in the entry point, the swelling, the anesthesiologist give 20 to 40 milligrams of methylprednisolone, depending of the extent of the ablation, and the pain is prevented giving paracetamol 1 gram infusion in 500 saline mLs. And always parameters of RF procedure should be registered. In this particular procedure, the total duration was 25 minutes. The RF activation time was 13:43 seconds. The energy delivered was 4.4 calories. The power supply ranged from 35 to 50 watts. Of course, you can increase the power when you are in the middle of the portion, while I use lower power when I'm near to the laryngeal nerve. The impedance used was ranged from 80 to 180 ohms. And this slide shows the clinical outcome in this particular patient. The volume before ablation and the TSH suppressed. And this image is taken the day after RFA. I always see patients the day after RFA in order to check any side effect. The image and the other advantage to see the patients the day after is that the image becomes clearly hypoechoic, and you see the total devascularization of the nodule. And this is the same image taken 6 months after RFA. The TSH became normal, 1.12, and the volume reduction rate, 6 months only, was about 80%, 78%. So an effective, beautiful result. And the nodule will shrink more over the time. So now I will come to the problem of intraoperative side effects, of to all side effects, which are divided in 3 sets of side effects: intraoperative, immediately post-operative, and late side effects. Intraoperative side effects. In this slide, we have compared the 40 patients which have been published in 2015 with the traditional technique. At that time, we had in 7 patients over 40, that is 17%, intense pain, which was none, provided that anesthesiologist gave paracetamol and methylprednisolone. So there was no complaint in the following 340 patients of pain. This is very important. Intranodular bleeding, we had this side effect as well in 3 patients over 40, that is 7.5%, and it was reduced to two only patients in the second set of patients with immediate RF coagulation. Again, pericapsular bleeding was observed in one patient, 2.5% in the first set of patients, and adopting specific precautions and having the anesthesiologist, it was reduced to only 1/314, that is 0.33, with immediate compression and after RFA and ice pack. But a vasovagal reaction was observed in one patient in the first set and in no patients in the second set of 314 patients. I think that it was due to the presence of the anesthesiologist. In any case, the anesthesiologist had atropine ready to use. Cough was observed in few patients in the first and in the second set. It's a minor side effect. You should power off the electrode needle and reposition it. It happens when the electrode needle is too close to the trachea. And now the second slide, immediate, within 24 hours post-operative side effects and specific precautions adopted. Swelling was quite common with the traditional technique, and it was observed in only 3 patients over 314 with immediate methylprednisolone intravenous administration. Cutaneous burn was observed in one patient over 314 in the second set of patients. Most importantly, the transient laryngeal dysfunction was observed in 5 patients, which is 1.59%. I must say that in the second set of patients, the ablation was really pushed more, close to the laryngeal nerve in order to obtain more complete ablation of the thyroid nodule. So this explains this data, which was not permanent at all. In all patients recovered, or either immediately or after a few weeks, or using dextrose 5%, as suggested by Professor Beck, cold dextrose, ice pack, and one patient had phoniatric reeducation, but she recovered after 3 months. And finally, peri-procedural side effects, where bruise is not a real major side effect. We had bruise in a few patients, and you may prevent it with immediate compression with ice pack. We had fever in one patient, no fever with the oral methylprednisolone course, no pseudocystic transformation, no nodule rupture in the second set of the patient. So I would advise to use this oral methylprednisolone course after RFA for it's 16 milligrams per day for 15-25 days, depending on the extent of the ablation, with a step-down approach, and in the same time, lansoprazole. In the same time, during a methylprednisolone administration, lansoprazole is used in order to prevent any gastric side effects. And these are the results which I published as early as in 2015 in the first set of 40 patients. And these are this slide shows the actual volumes. The median, this is the median, which was about 25, with a large variation. And over 2 years, it became 5 mLs with a mean volume reduction rate of -80. But I believe that now we have even better results. So volume reduction rate of 80% is not bad at all. And in the same paper, and this is as far as I know, is the only published, we assessed health-related quality of life, which should be the primary goal for patients. Yes, we measure volume reduction, which is a measurement, but how the patient feels after the procedure. And the PCS, the physical component summary, improved after 1 year and 2 years, but more importantly, mental component summary improved greatly. 1 year and 2 years, the results are comparable. In 1 year, you obtain already the maximum result on this aspect, and this means that the patients feel good. It's very important. As well, we observed an impressive symptom and cosmetic score improving after 1 year and 2 years with a visual analog scale. I will finish my presentation with these take-home messages. RFA is a reliable new tool for the treatment of solid benign thyroid nodules. RFA can be also indicated for pre-toxic and toxic AFNT. Ultrasound and laboratory tests are mandatory tools for patients checked before and after thyroid RFA. As I've shown you, thyroid, especially if you want to obtain complete ablation, which is the real goal, may be a complex procedure. A specific operator skill are required. So we heard yesterday Giroux talking about the learning curve, which is not short. Best results are obtained when nodule ablation is complete. Side effects are minimized through the aid of an anesthesiologist and adopting specific precautions. Thank you.
Thank you, Thank you, Dr. Valcavi, for this exhaustive presentation. Is there any question?
You asked me to remind you if you can show us the 2 punctures procedure.
Yes.
Because I have a case of a 7-centimeter nodule that I have to do it with 3 punctures.
Yes. For 10 mLs, maybe 1 entry point is enough. But I have a slide, casually, have a slide showing 2 entry points in this large nodule. So in some nodules, 2 entry points are advised. These images show how it is large. So I do, in these cases, I do the first part, the lower part, because I take care of the danger triangle first and the upper part in a second step. So this slide shows exactly the same images in, as I shown before, in a bigger nodule. We did in our series, we did a nodule as big as 100 mL. So this is the second puncture. And the needle in this case is placed in another plane.
Other questions? Roberto, what is the percentage of regrowth of your nodules in the long term?
Of? Sorry?
Regrowth of the nodules.
Regrowth. Well, as far as you perform complete ablation, the regrowth rate is very low. So there is I presented two sets of patients. In the first set, we had regrowth in about 30% of patients because they were not completely ablated. In the second set, the regrowth was 10%. There is another consideration that in spongiform nodules, the structure of the nodule is very important. In spongiform nodules, the heat spreads better, and so complete ablation is obtained without pushing at the extreme of the capsule, but provided that you have enough skill, then the nodule regrowth is up to the operator, really.
And I have two questions. At first, about the side effects, for example, fever. Why do you use the methylprednisolone? You have a special protocol or no? You can use another drugs. It's not very strong for a fever?
Well, methylprednisolone prevents several things. Prevents fever, prevents swelling, prevents the most awful side effect, one of the most awful side effects, which is tumor rupture. Tumor rupture occurs within a month. It is due to granulocyte migration at the site of the ablation, and it happens when you push very much the ablation and you give high energies. So granulocytes release lithic enzymes and melts the nodule. I don't believe that the explanation we discussed yesterday, I don't believe much the explanation is the entry point, because the breach made by the entry point, as Dr. Roos said yesterday, because it happens 1 month later. So there is time to repair the breach, and methylprednisolone is really useful when patients complain after a while some swelling, and you prolong, in this case I prolong the methylprednisolone course in order to prevent, and I was successful to prevent a tumor rupture.
Question about the hydrodissection. When you start your procedure, when you use the hydrodissection, and which kind of serums do you use?
Hydrodissection is recommended in patients when you have laryngeal dysfunction after procedure, immediately after. So I didn't do any malignant tumors or metastatic nodules, lymph nodes. So I've no experience. Maybe Professor Beck will say something later on this.
I think that is a barrier and a thermal barrier, and
Yeah,
from
but the problem is that hydrodissection lasts shortly. You have to inject all the time dextrose because there is no
It absorbs.
barrier. There is no barrier. So it's useful in this specific, in benign nodules, is useful for specifically for laryngeal dysfunction, and patients do recover in a short time.
Thank you.
Roberto, I wonder if we have two nodules, one on the left and one on the right, we can do it contemporaneously, or we have to bring the patient another time?
Yeah, good question. If we have, I would like to hear the opinion of the other experienced RFA ablators. In the case, the nodule, there is a dominant nodule on a side, and the contralateral side, I have small nodules. I mean, 5 or up to 10, but no more. I do all nodules in the same procedure because I didn't observe any major swelling, but in huge nodules of both parts, my observation I did with the laser, so it never happened I used the laser for 10 years before converting myself to radiofrequency. So I had a patient who had a bilateral ablation and had difficulty in breathing immediately after procedure. And I gave him cortisone and nothing happened, but it was a scary complication because the trachea is in between. So if you do two huge nodules, one on the right and one on the left, the trachea could be compressed, and advise patients to perform in 2 times. In this case, to perform in 2 times the procedure.
Morning. I'm Juan Carlos Percois. I'm endocrinologist. I'm from Madrid. In our experience, the jaw pain is common. What is your experience?
No, not really. In my experience, in my patients, given that paracetamol is administered thereafter, and I didn't show another tip, I put a small amount of ropivacaine as well. Ropivacaine is a long-acting anesthetic. So in no patients we observed any pain. Maybe they have some soreness the day after, but it's very bearable. So I'm happy with this.
Thank you, Professor Valcavi. Thank you for your nice lecture.